indicate so. So use the Q&A function to say, I would like to ask my question personally or live. And remember that this broadcast is simulcast in both English and French. So all you have to do is go to the globe icon at the bottom of your Zoom app, choose either English or French. So you can make your selection now as Francois translates that for me in French. Francois?
Bonjour et merci à tous de vous être connectés. Afin de pouvoir poser vos questions, merci d'utiliser l'outil de Q&A présent dans Zoom et de préciser votre nom et votre média. Nous pouvons prendre vos questions en live si vous le souhaitez. Merci de le préciser aussi. Et enfin, si vous voulez entendre la conférence en français, vous pouvez utiliser l'outil d'interprétation et sélectionner le langage dans lequel vous souhaitez entendre la conférence. Merci.
Thank you very much. So let me just now take the time to introduce you to our esteemed panel from Brazzaville, the Republic of Congo. We're joined by Dr. Matsidi Somwedu, who's the WHO Regional Director for Africa. In Dakar, Senegal is Mr. Prosper Minto, who's the Regional Director for Western and Central Africa International Civil Aviation Organization, that's ICAO. And Professor Salim S. Abdul Karim is the director for the Center for the AIDS Program of Research in South Africa. He's also the co-chair of the Ministerial Advisory Committee on COVID-19 and the Department of Epidemiology, Mailman School of Public Health, Columbia University. He joins us from Durban in South Africa. Welcome to you both. It's a pleasure to have you speak to us about this very important subject. Let me start with you, Dr. Mwede. I think there is a lot of anxiety seeing what is happening in Europe. If you could please just give us an update on the current situation with regards to COVID-19 in the region.
Okay, thank you very much, Tsepiso, and as usual, very sincere thanks to our APO group colleagues. Good morning, good afternoon, bonjour à tout le monde, and thank you all for joining us for this press conference on the possible resurgence of cases in Africa and how countries are preparing as we approach the holiday season. And indeed, as we see what's happening in Europe, all the discussion that's going on about Thanksgiving in the United States, for example, as there too, we see a significant uptick. So what does that mean for our region? I'm really pleased to be joined by Professor Slim Abdul Karim from South Africa. Welcome, Slim. And Dr. Prosper Zominto, who is the ICAO, International Civil Aviation Organization, Regional Director for Western Central Africa. Thank you so much for having joined us today. So indeed, we're now nearing the time of the year when people travel to spend their holidays together. These end-of-year get-togethers are a key part of our lives in African countries as well as worldwide, but they certainly can increase the risk of COVID-19 transmission. Greater mobility and large gatherings, and even small gatherings at the family level, can lead to new clusters of cases in parts of Africa that might previously have been spared. This comes as African countries are experiencing a concerning uptick in cases. There are now more than 2 million COVID-19 cases in Africa, and sadly, 48,000 people have lost their lives. In the 47 countries of the WHO African region, mainly sub-Saharan Africa plus Algeria, there are more than 1.4 million reported cases and 31,800 deaths. In the past 28 days, cases have increased compared to the previous month in 19 countries in the region, including countries like Kenya, Algeria, Ghana, and Angola. In most of the affected African countries, the rise in new cases is coming from workplaces and family gatherings. And of course, we know that there are several political elections coming up in a number of countries, campaigns going on, and gatherings as far as that is concerned. We see that people are starting to relax around colleagues and loved ones. I can tell you, I see that in our office as well. I've become a big scold of colleagues asking them to remember some of these measures, and we see that in communities. And it's hard not to, really, when physical distancing measures has kept us and kept people apart for so long. So there's a certain level of fatigue around this, and the upcoming holiday season may simply exacerbate this situation. We do know that outbreaks spread socially, and we can stop them with safe social interactions. So I'd like to ask everyone to be mindful of your individual risks and the risks of your loved ones and friends and neighbors. So we're encouraging meet outdoors where possible, avoid mass gatherings, absolutely, continue physical distancing and practicing frequent hand hygiene and wearing a mask, particularly around older people and those people who have diabetes, hypertension, those comorbidities that make them vulnerable to severe forms of the illness and even risk their lives. Wearing masks can save lives. This is why WHO is launching today the Mask Up, Not Down campaign, which aims to reach over 40 million young people in Africa on social media by the end of 2020. It's clear to us that somehow the way of getting the message out needs to be adjusted now, that people have done relatively well in the past, but we need to re-engage, re-energize, and help them better to sustain some of these measures. In addition, sustained and scaled up public health measures remain important, including testing and using test kits to find cases quickly, to find their contacts, and to stop chains of transmission. In the past 2 weeks, we've seen promising news with initial data from phase 3 trials for 2 COVID-19 vaccines indicating high levels of efficacy, 95% or so. We are now working with African countries on readiness and preparedness to roll out the vaccines, even as we await the final results of the trials, and even as we work in the COVAX, this partnership platform, to make sure that enough resources are available for the work that needs to be done. Finally, some good news. While fighting COVID-19, WHO has also been supporting the Democratic Republic of the Congo to control its 11th outbreak of Ebola. Yesterday, the government declared it over. This is a big achievement as it took place over a huge and often inaccessible terrain. So innovations used to fight Ebola, such as technologies to keep vaccines at super cold temperatures, will be helpful when we're bringing on board a COVID-19 vaccine to Africa. So I'd like to commend and congratulate the communities, the frontline healthcare workers, the authorities, and the partners who work together to contain this Ebola outbreak. Through collective action and using public health tools like active case finding and contact tracing, we can bring an end to outbreaks. I look forward very much to our conversation today, and thank you once again for having joined us.
Thank you very much, Dr. Mweti. Some great and exciting news that certainly will give us hope with regards to our fighting the pandemic. So let's move on now to talk about how other regions are experiencing it, especially country to country. We introduce now Prosper Zominto. Could you tell us, just in terms of traveling by air, how safe is it during the holiday season? What are the preparations underway in Dakar, Senegal? And are you seeing evidence of a resurgence?
Thank you very much. It's always a pleasure to have this type of meetings with my sister, Dr. Matsiriso. And I will welcome Professor Salim Abdul Karim to this panel. I am an engineer by profession and the ICAO Regional Director for Western and Central Africa. And we are glad to host the WHO Regional Office in WACAF, as we say in short. I would like to share, to be in the same good mood as Dr. Mweti, in that In the technical area, talking of aviation, we have made a lot of progress since we started addressing this pandemic in the aviation sector. A set of measures published by the ICAO Council have been disseminated to states, have been implemented, and we are still assisting states in implementing these measures that covers operational safety, technical issues, public health aviation related issues. And since July, we can witness the restart of operation. There are now flights. I have a colleague just coming from South Africa to Dakar. We have daily flights now starting. We are far from the nominal capacity that we are used to, but at least travel is now back. Now, this traveling experience, we know we are approaching the holiday season, as we call it. We have Christmas, we have end of the year, we have the New Year celebrations, which are family events. And we have the challenge of capacity, but we can do more than what we have. We are like 60% less as compared to the capacity that we had last year, that is in 2019. And we are now focusing on the area of public health measures, working closely at global level and regionally with WHO. There is still room for better harmonizing the measures, coordinating, so as to facilitate the flow and the regularity of flight operation in the region. Dr. Murthy mentioned the issue of testing. Though it is not universally a requirement, but some states have done it. They are sovereign states, and they have the authority to implement the measures that they want to implement to mitigate the pandemic, but they are not harmonized. This is an area we are working on. We also have the public health corridors. That is a set of measures to be taken to secure, to really make air transport safe, public health-wise, safely. And this also require that the states involved, that is the origin and destination of the flight, those states needs to talk together and really align the measures to facilitate transport. So for now, this is what I can say, Tsepiso. Over to you.
Right, thank you very much, Mr. Mentor. So we appreciate that sharing of the experience, especially in Dakar, Senegal, particularly with regards to the aviation industry. So let me now hand over to Dr. Salim Karim to talk a little bit more about South Africa. I know recently the health minister held a press briefing about the worrying number of cases that they're seeing there. Dr. Salim, it's over to you. It's always a pleasure.
Thank you very much, Ms. Makwekla. I'd like to acknowledge the presence of Dr. Moeti and Mr. Zuminto. It's a great pleasure and honor to be here with you at this briefing. I'll briefly comment on three things. The first is, what have we learned about the second surge by analyzing countries that have had a second surge? The second is I'll talk about the three key risk factors for a second surge, some of which Dr. Moeti has already touched on, so I'll do that very briefly. And I'll end off with talking about what are some of the proactive steps that we've taken in South Africa to prepare for a second surge. So firstly, What have we learned about the second surge? Well, in an analysis that was done by one of our centers of excellence in South Africa on epidemiological modeling, they looked at 49 countries that have experienced a second surge. When we look at those, of the 113 countries that have completed their first surge, 49 have had a second surge. So about half of the countries have already experienced a second surge. Of those 49 countries that have had a second surge, 24 of them, the surge was worse than was expected from the first surge. So we are seeing quite a level of variability between the evidence from what we are seeing in terms of the first surge and the second surge. Some variability, some being worse, some being a lot milder. What does that tell us? It tells us that based on those averages, we have to expect that at least half the countries in all likelihood will have second surges in Africa. We look at the situation in South Africa itself, and when we look at the data from the 49 countries that have had a second surge, we noted that the average from the end of the first surge to the start of the second surge is 66 days, so roughly about 2 months. Based on that, when we look at several of our countries, we should expect to start seeing second surges occur in some of our countries. In South Africa, we currently have an outbreak in one part of our country, in the Eastern Cape, but that at this point is localized and is not a second surge. However, should it spread and should it become an established level of wider community transmission, it could lead us into a second surge. There are three key risk factors that are driving the second surge, particularly in countries like South Africa. The first is complacency. The level of complacency we're seeing, and it's being widely reported in a meeting recently where I met with many of my counterparts, the chief government scientists advising their governments. We've noted across the board, whether it's from New Zealand or whether it's in Vietnam or in India, pandemic fatigue is a reality and is quite widespread. And people are just not maintaining social distancing and wearing their masks to the same extent. The second are super spreading events, and we are deeply concerned at what we're seeing in South Africa. So several super spreading events have occurred at universities. As universities have opened, students share a lot of facilities, they have parties and functions, and so we've been seeing outbreaks occur now in at least 4 universities. So it's becoming an issue, and it's not only in universities. Super spreading events are occurring in gatherings, at funerals, and so on. And then thirdly, we're quite concerned about the coming December vacation. This virus likes people to move, because that's how it spreads. And we anticipate over our December vacation period, there will be several million people who will be moving from inland to the sea in our coastal areas, and we will see quite a lot of family gatherings, especially and deeply concerning intergenerational gatherings. So those three issues, the level of pandemic fatigue and complacency, the super spreading events, and then the movement and family gatherings in December, we are concerned would create the opportunity for a second surge to establish itself, particularly I'm referring here to South Africa. So thirdly, what have we done? Well, we started planning for a second surge just as we were at the tail end of the first surge. And we have in place a resurgence plan for South Africa. And that's now been widely adopted by the various provinces and are being implemented. This plan puts out in quite a lot of detail how we will do the three key things. The first is, how are we going to monitor when we are heading into a second surge? The indicators have been identified, the criteria and the threshold have been identified, and the way in which we move from the alert phase into the response phase is well mapped out in the resurgence plan. In summary, we look at the number of cases, and we look at it not on a daily basis, but in terms of 7-day moving averages. We look at the positive test proportion, and we look at hospital admissions. These three indicators tell us whether we're seeing an uptick, whether we're seeing an outbreak, whether we're seeing a resurgence, or whether we're seeing a genuine second surge. And we've set criteria to define each of these. The second thing that this resurgence plan puts forward is the way in which district and provincial response teams need to intervene. We see it very much that we can prevent a second surge if we deal with outbreaks as and when they occur. We talk about, fighting the small fires so that we don't have a raging inferno. And so that's the basic plan. Every time we see an outbreak, every time we see a surge of cases, we try and intervene to slow it down. And then finally, in this resurgence plan, we talk about how the interventions need to be put in place in the run-up to the second surge. And in the midst of the second, the 9 intervention areas are identified. They range from leadership and coordination to facility readiness and medical supplies, and all the way through to engagement with the communities and communication. So I hope I've given you a sense of what the evidence from the other countries that have experienced a second surge looks like, given you the 3 key concerns we have that might lead to a second surge in South Africa, and I've given you the 3 key components of what is the main elements of our resurgence plan in South Africa. Thank you.
Thank you so much, Professor Karim. I'm sure that's going to elicit quite a number of questions. We already do have questions, and I'd like to just repeat to my colleagues that if you want to ask a question, please indicate so in the question and answer session. Also, please indicate to whom you'd like to ask the question. More importantly, if you want to ask a question live, please also indicate so. I do believe that we have people who have indicated that they want to ask the questions live. Dr. Nimat Ala Abdel Rahman from Al Rahman newspaper in Egypt. I know you wanted to ask your question live. If you are connected and you are able to do so now, please do so. And I know we also have Wilson Wambua from Uzalendo News in Kenya, who also wanted to ask their question live. So are you both connected? Okay, so if not, then let me just go ahead and then ask a question that was posed from Egypt. So I'm going to read it out. Dr. Mweti and Professor Karim, if you could just attend to this as well, this question. So it says, has it been confirmed that the virus present in Africa is the same as what is happening in other countries? And also whether it's the same phase, or whether the virus present in Africa is the same phase present in countries that produce vaccines. So I'm assuming that if it's been designed for the kind of virus infection that we're facing, and will it have a role in stopping the infection? So there's also the issue of when it will be introduced in Africa, whether it'll be distributed at the same time as Europe, and what support will Africa get from the organization to fight the virus, that is the WHO, and in what forms? Dr. Mweti, I know it's quite a mouthful if you want me to remind you, because it is rather convoluted, so I'll hand it over to you.
Yes. Okay, thanks very much for that question. I think is the virus the same as what has been found in some countries that are producing the vaccine? The virus type that has been circulating in Africa essentially is linked to transmission from Europe. And I think it's a similar virus that has circulated between different European countries. So most of the cases in Africa arose from travel from Europe and the the viral studies that have been carried out show that it is indeed linked to types in Europe. So since one of the vaccines was produced in a European country, and we are having several of the vaccines that are progressing to be produced coming out of Europe. So hopefully the expectation is that, yes, it will be effective in African populations. That's the Pfizer virus. And our expectation, eventually, the outbreak in the US is also linked to Europe primarily, in addition to China somewhat. So our expectation there is that the viral phenotypes that are present there, where the study was carried out, will also be relevant. And we know that the vaccine was tested in several places as well. Maybe Slim will correct me. I know that South Africa got involved in a couple of the trials. Perhaps we can see if it was also tried out in South African subjects. What is WHO doing? We have, as far as the vaccine is concerned, there is a coalition platform that's been established at the global level between different countries. All of our African countries virtually have joined it. Quite a few other countries in regions like Asia, regions like Latin America, and also some European countries are partners, including some EU countries. The idea is to pool efforts, pool the resources, create the amount of money available, and create the size of a market to be able to compete and make agreements with the pharmaceutical companies that are developing and are going to be producing vaccines to be able to get the supply of vaccines. As we know, there's a very hot competition at the global level to reserve doses so that they are available to countries to make a difference and start to bring the virus under control. So this COVAX, it's called, it's part of the ACT Accelerator platform that is coordinated by WHO, by Gavi, the Vaccine Alliance, and by a number of countries from Africa, from other regions as well. There's been a mobilization of resources, a very good response on the part of both middle-income countries, those that are going to be self-financing, and the low-income countries that are going to be supported with funding from some of the donor countries and also from the World Bank. There are still gaps. I believe we still have something like a $4 billion gap in the financing for vaccine procurement. And most importantly, of course, there will be resources needed as well for the delivery of the vaccine, for all the actions to deliver the vaccine. As I said in my statement, in WHO, we have started working with countries to assess their readiness to roll out the vaccine, and also to be prepared then to cover the gaps so that they can roll out the vaccine. I have to say, one of the most challenging issues is, of course, the cold chain requirements of the most promising vaccines, one of which needs a -70, the other of which needs a -20-degree temperatures for it to stay effective. And we're going to have to work with countries to see how this can be made a reality as well.
All right, thank you, Dr. Professor Karim, if you'd also like to weigh in on that. The other part of the question was the length of time of the vaccine in terms of its efficacy, as in, will it stop the virus right away, or is it something that would have to be taken periodically?
Yeah, thank you very much. I'll address the three questions, I think, that dealt with areas that I've been working on. The first is, yes, when we've now sequenced just over 2,000 viruses, the SARS-CoV-2 viruses from throughout Africa, and when we look at those viruses, there are two things that are quite striking. The first is the stability of the spike protein, and in particular of the receptor binding domain, the RBD domain. And the reason why that's really important is that we're not seeing a level of variability in that spike protein, is that is the specific area that the vaccines that are being developed is targeting. And almost every vaccine is targeting exactly that area. And that stability is very reassuring because it suggests that if the virus mutates that, it does not survive. So that variants of that particular domain are not doing well. So that level of stability means that vaccines that have been designed based on strains that come either from Europe or from the US will be equally effective in South Africa or in much of Africa. So as it stands right now, there's no reason to believe that the vaccines that currently have shown efficacy shouldn't be anything but as equally effective in Africa as they have been in the clinical trials. The second issue that was raised was around the actual protection that they provide. So right now, what we have been able to basically answer from the 3 clinical trials that have released results is that we've answered a key question. That is that a vaccine against this coronavirus is feasible, and we've been able to make one. That was a question we didn't know we didn't have an answer to barely 2 weeks ago, because until 2 weeks ago, humankind had never developed a vaccine, again, effective vaccine against a coronavirus before. So now we know we can do it. Now we also know that we have a very high level of efficacy. The most recent data released 2 days ago from Pfizer and BioNTech shows that of the 170 infections that occurred, 162, I think it was, I stand to be corrected, were in the placebo arm and only 8 in the vaccine arm. So the level of efficacy is really high. The efficacy was constant and consistent across the different ages, the different demographics that they had in the study. So it's very reassuring. The other 2 trials, the Moderna trial, showed similarly high levels of efficacy at 94.5%. And we saw from the Gamaleya Sputnik V vaccine, 92% in a much smaller trial at this stage. So what we're seeing is a level of consistency across these 3 trials, and all 3 of them showing high levels of efficacy, no concerns relating to safety at this point. And based on that, we are quite confident that we would likely to see licensure of these vaccines once the regulators have looked at it, and then comes the process of access and so on. And I'll just touch on the last issue that was raised that Dr. Moeti has already touched on, which is that I had never heard of the word vaccine nationalism until a few weeks ago. And now it's come to represent some of the worst traits of our humanity, that there's a fundamental belief that those who can afford it should use their financial clout to secure all the vaccines or as much of the vaccines as they wish, and the others are left to fend for themselves. That's indeed a very sad situation to see and to witness, because it's based on a very fundamental error. And that error is that a country on its own can be safe while the rest of the world is not safe. That is simply not a reality based on what we've seen in the way in which this virus spreads. So one of the positive features that is directly addressing this vaccine nationalism is the global solidarity that we are seeing in COVAX. It is something we saw in the Global Fund, in UNITAID, in PEPFAR, where countries that were able to afford it were able to assist those who were not able to. And COVAX is doing exactly that. It is providing a platform for those who can afford it to assist those who can't afford it, and to ensure that we have some measure of equitable distribution, which Dr. Moeti has so well outlined. Thank you.
Thank you, Professor Karim. So we're moving on to more questions, and a reminder, if you want to ask a question live, you're able to do so. Jean-Richard from RFI, I know you said you wanted to, so if you are available, let us know. But let's start with Maggie Fick from Reuters. Maggie?
Hello there, can you hear me, please?
Yes, we can. Go ahead.
Great. This is Maggie from Reuters, and my question is for Dr. Moeti. Do you have any comment, please, on the report this morning from Addis Ababa in which the Ethiopian military accused the WHO director, Dr. Tedros, of supporting the armed forces in the Tigray region who are fighting Ethiopian troops? Does Ms. Moeti have a comment on this accusation, please?
Yes. Okay, thank you very much for that question. I think what I can say in response is that I know Tedros. I know him as somebody who is passionately promoting global health, promoting the good health of people, and promoting peace. Because I think it's only in the context of peace that we can have the type of development that delivers good health for people. I think this is the extent of my knowledge of Tedros as a person, as a colleague, somebody I've known over quite a few years. I do think if you need more information about what could be the possibilities, what has been happening, I'd like to suggest that you contact the Director General's communications team in our headquarters in Geneva.
Thank you, Dr. Moeti. So the next question is from Michael Maria from ENCA, and it's to you, Professor Karim. So what he wants to know is whether South Africa has passed its 66-day mark. I think you spoke about that earlier on. And if so, how many countries have registered a second surge after that period of time?
Yes, thank you very much. It's a good question. So yes, South Africa has passed the 66-day mark. The 66-day mark is a mean, it's just an average. It's actually quite a wide range. Some countries have really, for example, the US hasn't really come down to a trough. And so they had a second surge that had no gap between the first and the second. We also have seen in several countries that there's been quite a long gap between the first peak and the start of the second surge. So I think it's a high level of variability. I provided the 66 days just as an indicator of what the average is. And about half the countries are longer than that.
Thank you, Professor Karim. And just remember that there's a lot that we don't know about the aviation space, so don't forget that Mr. Mentor is here to answer those questions, especially with regards to the public health safety measures that he mentioned that the aviation industry is looking at taking. As Dr. Moeti mentioned, it is a time for concern because it's a holiday period. So we're going to move on now to other questions. We have a question from Jean-Richard from RFI. Jean-Richard, if you want to ask the question live, you may do so now, or I can read out your question. Okay, he's not here. So the question is to you, Dr. Moeti. With the rise of cases in some countries, can we say that Africa is witnessing a second wave of the pandemic or just the start of a second wave? I think it's really down to the technicalities of it. When do we say that we've entered a second wave? Dr. Moeti?
Yes, thank you. I think we can say that we are seeing, after a good period of downward trend, and then a flattening of the curve for some weeks in Africa. We had a plateau over some weeks. Now we're starting to see an uptick in cases. If we look at the region overall, and it is linked, and as Slim had said earlier, it's linked, it varies between different countries. It's linked to various factors, including what people are doing, the extent to which people are able to keep to the public health measures, the extent to which the public health capacity is built up so as to contain what might be clusters and stop them becoming wider community transmission. In some cases, it's linked to the weather, for example, whether, you know, as winter was setting in some of the countries in the south that saw winter, people had to stay indoors a lot more. It was perhaps then people might have been gathering in ways that are unsafe. That's part of what's happening in European countries. So we are seeing this increase in cases in some countries, which is linked sometimes to specific events. There is an election coming, people are gathering, there is pushing back by some religious groups. People are tired of doing their worship virtually. And we've seen in a couple of countries, in Gabon, for example, there was a demonstration by some groups of a church demanding to be able to finally have their services in person. There's been work to open up schools, concern about education, and some cases have gone up, and opening up businesses and dealing with the impact of the pandemic on economies of countries. I think what's important is, one, to anticipate that these upticks will happen. What we are doing in WHO as well is helping countries to do what we call intra-action reviews. So really drill down and analyze what's happening. What are we seeing in terms of the public health capacities? Some of the things Slim was talking about, the coordination, the local incident management, because it's not possible just to do this at the national level with a committee working with the minister. Ultimately, it needs to get down to the district level, to the local health facilities where they need to have the capacity to do the rapid, the testing, contact tracing, and isolation of people, and continue to engage the community and monitor and understand what's happening in people's heads, in their minds, and in their behavior. Are they wearing the mask around the chin, or are they constantly keeping it covering their nose? Are they simply tired of not gathering, going to restaurants? We see this where we are living. So my recommendation, our recommendation is that we should anticipate, especially now that these, whether we call it a second wave surge is coming, an uptick is coming, because economies are opening up, people are moving around, there is fatigue, we need to understand better. And the more local the intervention can be with built up capacity, the more engaging with individuals and groups and enabling them to inform themselves, encourage each other. And then the more targeted we can be about protecting the most vulnerable, is that we can prevent the worst impact of these surges.
Well, thank you, Dr. Moeti. Professor Karimi, I know Michael Marlier will like to hear from you, especially because I suppose, you know, ENCA has an interest, obviously, in the situation here in South Africa. What are you seeing and how are you measuring that?
My apologies. I didn't get to see what the question was.
Okay, so the question was about just with regards to the second surge. So how do you define it? Has South Africa entered that?
Okay. So when we look at the three key markers of cases, percentage of tests that are positive, and admissions, we can use those three to give us some indication about whether we are seeing just a small rise, which is temporary, whether we are seeing a resurgence, which is easing, rising up and easing, or whether we are seeing something that's a consistent and rapid exponential increase. We can piece that together based on those three markers. If we look at the issue relating to the confluence that you asked about in your question, what we're seeing at this stage is a concern that brings together the three problems that I raised, that we're dealing with the complacency at the same time as people having parties and so on, at the same time as people traveling and having family functions. So these three are coming together in December, and that poses quite a significant problem, because combined, these three will create a situation where the virus may end up spreading and may end up in a situation that it gets beyond our ability to ensure that we can do the contact tracing and keep a lid on the overall transmission rate. And that's what we worry about. We worry about a situation where it gets beyond our ability to keep it in check. And once it does that, it gets into general community transmission. And I'll answer the other question that was raised as well. Yes, antibody testing is a key part of our strategy. If you remember from our 8 stages of the response, the 8th was vigilance, and vigilance centrally involves monitoring the number of individuals who have that have antibody seroprevalence. And so we have in South Africa a large national survey underway. It's a very large survey. Over 30,000 people are being visited at their homes. We are trying to get a very accurate estimate of what proportion of our population have been exposed. Some early data from convenient samples in smaller studies have suggested that it could be in the region of around 20 to 30, even more %. But those are biased samples, so we'd like to get a better estimate. And as soon as those results become available, because that study is in the field already, we'll have a clearer understanding of the extent to which there's been viral exposure in South Africa. I think I've answered all 3 questions that were asked of me.
All right, thank you, Professor. So Esther Nakazi, apologies for keeping you waiting. I know you have a question that you want to ask live. Are you unmuted?
Yes, I'm unmuted. Can you hear me?
Yes, we can. Go ahead, please.
Thank you very much. And my question is to the 2 doctors, Dr. Moeti and Dr. Salim Karim. We have heard that the vaccine readiness in Africa is up to 80%. These studies that have been done have not analyzed as to who is accepting this vaccine. But we also know that, or I have heard of some small saying that health workers are not really vaccine ready. They are not ready to uptake the vaccine, and yet they are a priority people that you're targeting to give the vaccine to. So in terms of vaccine readiness, do we know who is saying they are ready to uptake this vaccine once it hits the market in Africa? Thank you very much.
Okay, thank you, Dr. Moeti and Professor Karim. Let me start with you, Dr. Moeti.
Okay, thank you. I would say the assessment of readiness is in its early phases. I think that the estimate that readiness is at 80% in the African region might relate to whether or not we have the kind of institutional platforms in place, whether there is a committee that is going to take certain decisions, whether there is a process to start the planning of for the vaccine, and whether there is familiarity with rolling out these campaigns for vaccines, which we know that African countries are used to doing. For example, we've been carrying out a lot of polio vaccines in quite a few African countries, and those capacities are going to be repurposed. But my sense is that we need, in the assessments that we are doing now, to look at such issues as you are raising. You know, healthcare workers are being prioritized because they're seen as the first defense, and we need to make sure that they stay healthy, and the healthcare setting is not where transmission happens, so they need to be among the priority groups. And it'll be necessary, of course, you know, even if they're healthcare workers, they cannot be compelled to take a vaccine if they don't believe in it. So the sort of intervention that we normally do with members of the public will need to be done with healthcare workers as well. So what I think is that we need to take note of some of these potential risks to uptake of the vaccine, particularly by the initial groups, and engage them in the sort of dialogue, sensitization, and reassurance that's needed. Health workers, we know, are very worried and have been very concerned about the challenges with personal protective equipment, and therefore their exposure to becoming ill from COVID-19. And some have been infected and some have died as well. they need to understand that the vaccine is going to play a very important role in protecting them so that they can continue to play their important role. And then next will be people with comorbidities who are among the most vulnerable. So making sure then that the vaccine protects against the ultimate negative impact, which is somebody losing their lives. And some countries are looking at some key sectors of their economies, which they're opening. So should it be people who are working in the tourist sectors, the hospitality sectors that have been so badly affected, people in transport, clearly. I think Prosper shared with us some of the work that's being done by ICAO together with ourselves to guide governments on how to ensure that testing happens. So if, one of the big issues in African countries has been international trade, those people who are carrying goods that are so essential to the economies of countries, should such workers be prioritized, because that's the way you're going to then enable free movement of people over and above some of the testing protocols that we are working on together with ICAO, so that at the same time as protecting populations, the healthcare settings, the most vulnerable, we are also contributing to the reopening of economies, which is so desperately and urgently needed in African countries.
Thank you. Professor Karim?
Sure. So I'll just share with you some recent data. So in an international survey involving 13,426 people from 19 countries in a paper published by Lazarus and others in Nature Medicine, they found that across these countries, 71.5% of individuals who were asked indicated that they would be prepared to take the COVID-19 vaccine. It is concerning that we have a situation where 28.5% said that they are more hesitant. What we found is that there's quite a large variation across countries. So the highest acceptance rate was in China, where just over 90% said they would take a vaccine, and the lower acceptance rates were in Russia, for example, where only 55% said they would take it. Interestingly, in South Africa, it was just around 66%, if I'm not mistaken. So what we do understand is that there is a level of vaccine hesitancy across the world, and including in South Africa, and that will need to be dealt with. So how significant is this problem of vaccine hesitancy? How much should we be concerned about it? Well, the World Health Organization estimates that herd immunity for COVID-19 is probably in the region of 60 to 80% coverage we would need. So if you do a back of the envelope calculation based on R0, it's around 66% of people would need to be vaccinated in order to achieve a herd immunity. So if you work with 66%, and if you've got 71% of the people accepting a vaccine, it means you've got to try and reach that 71% as best as you can. So you've got to achieve most of them, because the vaccine is 95% efficacious. So 5% of those you vaccinate will not be protected. So it would mean that everybody who is willing to take a vaccine will have to be reached and given a vaccine in order to achieve herd immunity. So the vaccine hesitancy issue really poses a major risk to achieving herd immunity across all our countries. And the extent to which vaccine hesitancy leads to a situation where people are just not going to take the vaccine, they place not only themselves at risk, they place the entire countries at risk. And so that's why it's an important issue for us to address and to engage with communities, ensure that people are well informed, and to depoliticize vaccines. Vaccines are a technical medical application. It's got nothing to do with politics, as it has become in the US and many other countries.
All right, thank you, Professor Salim. Mr. Mitchell, there's a question here from Goya Foster from German press agency, and the question is around Africa haven't passed the 2 million mark, and if this is a concern, especially for the aviation industry, and what are your thoughts just about the trajectory then, if we're saying we've passed that 2 million mark? I've got a question of my own, and it is around aviation safety, the science of it. There has been a notion that it would be safer to be on an airplane because of the air circulation, that it kills the virus. How true is this?
Thank you very much for this two questions. I will start with the last one. In this panel and the audience, there are many doctors, so I don't know how air in the plane kills the virus. It may be true, it may not be true, but I cannot evidence it. What I can say is that there are researchers showing that the risk to catch the virus, during the travel experience is very limited. We cannot have zero risk. That is really, really limited, because once all the public health, aviation related measures have been taken, passengers demonstrate they are safe. The risk to have the virus from the departure to destination is really very limited. Now, I was saying in the introduction that the focus is in harmonizing public health measures. Technically, when I say, when we in aviation, we are talking of safety, we are talking of the safety of flight. This is not an issue as such. It was an issue during the restart of the operations, because pilots were idle, air traffic controllers were idle, aircraft were grounded and needed specific maintenance. So the concern was to maintain the recency and currency of aviation professional, and also ensure that the airworthiness of aircraft is maintained. This is, we don't have, at this stage now, we no longer have concerns about it, since states have been started implementing the measure. So the main thing is how now to ensure a flight is taken at a given time. We know when you have flight details, time is a key factor. We are used to a flight departing at such time, arriving at another time. So depending on the protocols that are being implemented by states, you just mentioned testing, there are some other protocols. This is where the challenge is, as to, do we have the capacity to process the volume of passengers that want to travel, and still make sure flights are taken timely and arrive timely? Thank you.
Okay, so now let's move on to this question from Gabrielle Stanheiser from Wall Street Journal. And the question is about the estimate of how much distributing the vaccine will cost. So that is the ones made by Moderna or Pfizer in Africa. And would it be practical or affordable? And when do you expect will be the delay between a vaccine being available in the US and the Europe versus Africa? So Dr. Moeti, I'll start with you, and then Professor Karim, you can answer thereafter.
Okay, thank you. So I think that, as I said, there is the COVAX platform, which has made estimates of the amount of money that is needed, which is aiming to have about 2 billion doses available and distributed in countries by 2021. So far, the amount of money that's been raised both for the procurement and partly for the distribution of the vaccine is about $5.1 billion committed by various contributing countries, the EU, Korea, the Bill and Melinda Gates Foundation, and others. And it is estimated that we need now, for the beginning, about a further $4.2 billion for the entire COVAX. I don't actually know the numbers for Africa specifically. I can get those from my colleague, and we can get you that information. And then for 2021, we'll need about $23 billion for this platform. We can get the amounts that are needed for the African region. The aim is to, I think, being realistic, and I very much align with the statement made by Slim around vaccine nationalism and the unfortunate situation that we're seeing. But we think that the move that was made in advance to establish this COVAX to pool efforts is a very positive step, and that gives us hope for African countries. So we are expecting that we will be able, and I know that we have been in discussion with the Moderna for that vaccine, to be able to get some of those supplies as soon as the vaccine becomes produced and available as part of the market. I believe that the COVAX is starting to have discussion with Pfizer. And the idea is not to try to have everybody vaccinated in all the countries. That's impossible. That's why there's been a prioritization, and an aim is to reach about 20% of the population by the end of next year, starting with 3%, those who are the most critical, highest priority groups, to be able to start to have an impact on the vaccine. Will Africa be able to get the vaccine completely at the same time as some of the Western high-income countries? I hope that Africa will be able to get the essential supplies to start to have an impact in slowing down the spread of the virus at the beginning, due to the efforts and the solidarity displayed in this COVAX platform. And I hope that as time moves on, other countries are willing to, if you like, concede that you may not need to try to cover all your population at once. I think Slim said it very well. If we all work at prioritizing the most vulnerable, the most critical to healthcare, to economies, then I believe we could have a fair process of access, a more equitable access, and not the usual African countries at the back of the queue, which we have experienced in the past with other new technologies. Thank you.
Thank you, Dr. Mweti. So let's just get final comments now. Mr. Minto, I'll come to you. If you could just give us your final thoughts on how to be better prepared, not only as individuals, but as countries, especially in the airspace arena.
Yeah, thank you. My mic is on. Can you hear me?
Yes, we can. Yes, we can.
Okay. Thank you. In conclusion, I think we had very interesting discussions and questions, and the clarifications were provided by our knowledgeable panelists, I mean the doctors, as far as public health aspects are concerned. I want to be optimistic. Though Professor Karim warned on the likelihood of second surge, at the same time, I think we have learned a lot from the first wave. Capacity has been built, though very slowly. and we have been able to restart flight operations. So in terms of air transport, we think states are ready at least to offer the travel experience for those who want to travel for business, for family reasons. We just mentioned the season we are in for the next 2-3 months. It is there, but how to make it, to go back to the performance that we are used to, that is until December last year, this is a challenge. And I think Dr. Moeti will have words, but we have, as individuals, as a public, as a population, we are the first responsible, because it's about our safety, it's about other safety, our family members' safety, beloved safety, and there are a set of measures to be implemented. We need to behave according to the guidance that is provided, that is for our own and others' safety. That is in addition to the efforts being made by states, thanks to science, the advancements. We have good news also that will help build the confidence in the public for the travel experience as far as air transport is concerned. So I thank you for the opportunity again. Thank you, Dr. Karim, for the light shed in these discussions, and obviously my sister, Dr. Moeti. We thank you.
Thank you very much, Mr. Minto. So, Professor Karim, to wrap up, we've got 2 questions, one from Ruth McLean from the New York Times, and the question is about what has the pandemic taught us about the collection of basic statistics across the continent, especially births and deaths. And there's another question from Lynette Atieno. Would you advise countries to go back to restrictions such as lockdowns? I'd imagine more hard lockdowns, as many African countries are now lethargic and don't care about the guidelines. What do you see as a solution? Professor Karim?
Sure. When we look at the situation right now, we are in quite a different position to respond to this virus than we were in March of this year. We know a lot more, and our understanding about how to control this virus is much more finely developed. It's not an easy, it's not a simple concept to talk about lockdown, because lockdown means different things to different people. If we are talking about a lockdown as specifically relating to stay-at-home orders, I think we will see that very rarely being implemented at this stage, because it's really a point of last resort. It is only something that countries, I suspect, will go to when the health services are being overwhelmed and the situation is beyond control. We should really get to that position, because we know how we can control the spread of this virus. And so the way in which most countries are approaching the current situation, the current waves, is at a much more localized level. No longer moving into national interventions to solve local problems, but rather using the evidence and the data at a local level to address it, so that different reasons for the spread of the virus can be dealt with differently by each locale. I think I forgot the first question. My apologies.
No problem. Let's go back to that. So the first question was about the lessons that we've learned from the collection of data, births and deaths. Yes.
Yeah, so when we look at the evidence that's being collected, I mean, COVID-19 has created a whole new world for us, that you can access data on any country, anytime, And it's all widely and freely available, either through World in Data or the Johns Hopkins University website. So when we look at the evidence that we are seeing throughout Africa, and it's being analyzed on a daily basis by the African CDC, and it's being done according to the different sub-regions, we have a better understanding of what the trends are across the board. But we should be aware of trying to overanalyze any one of the markers. And I think that that's one of the lessons we've learned from looking at the data. You've got to look at them in conjunction. So if you're not testing enough, then you will not see a rise in cases. But if you're not testing enough, you may see a rise in the proportion of tests that are positive. And so that becomes a more important marker. And so it just depends on what your testing strategy is that enables you to interpret your case data accordingly. And you must remember that most countries change their testing strategy because you need different testing strategies, different stages of the epidemic. So that also has to be taken into account. I think ultimately, the one thing that is a really good indicator is admissions, because you can hide many things or not report many things, but admissions is hard to hide because patients are sick, they come to the healthcare service. And when they do come to the healthcare service, whether they have access or not, and whether they get admitted or not, you have some idea of what the burden is that's pitching up. So when we look at it from the African Coronavirus Task Force, we ask our colleagues across the various countries whether they are seeing cases in the hospitals, and the answer at this point is no in most countries. So we tend to believe the evidence that we're seeing in terms of cases, percent positive, and deaths, because we're not seeing the admissions to the same extent. So I think all of these put together gives us some better overall interpretation of the data. And that's something we've learned in the course of this epidemic. Thank you.
Thank you, Professor Karim. And finally, Dr. Moeti. So we've got a question from Naftali Maura from Xinhua News Agency, and it's about the second surge in Africa. How long do you think it'll last in countries like Kenya, he asks, and is there any sort of magic pill to avert worst case scenario, which he says, for example, the overrunning of health facilities and the high number of fatalities. And there's also another question here from Punch, Nigeria. So apparently it's reopened some 37 orientation camps across the country for National Youth Service Corps programs. And there are a lot, according to him, the numbers are in the thousands in each compound, and there's a lot of physical activity, which he says makes mask wearing uncomfortable. What kind of advice do you have for these organizations or programs? How should they run the camps to ensure that there isn't a spike in cases? And under these circumstances, do you foresee a spike in cases? Dr. Moeti.
Okay, thank you. I think, I mean, in relation to the increase in cases that we're seeing in a number of countries which have opened up their economies and people are moving around, I think it's difficult to say how long we expect these to last, but we certainly know what needs to be done about them. So, and I think I can only repeat what Slim has said. First of all, we need to know where these cases are. In most of the cases in African countries, this has been very much an urban phenomenon. So it's something that's happening in the large cities, in some of the towns. Of course, sometimes when travel has been opened up and people are able to go from the capital cities to their home districts, then we see clusters and sometimes community transmission in places where people go to, especially if there are gatherings going on there. So I think that in order to know and to anticipate some of this, we need to be aware what's happening in some of these countries. As I said, there are countries where there is election campaigning going on, so you may see movement and gatherings countrywide. There are cases where people are going to be traveling out of the cities, but it is largely in the urban areas that we are seeing upticks because people are moving around and gathering more. And we need to drill down on the data there and look at what has been happening. As I said, we're helping countries carrying out interaction reviews to assess the degree to which the different interventions have been effective. So the key public health work, the testing, and I agree with Slim very much that the testing strategies have changed. For example, we are seeing in a number of countries, some low-income countries which have had challenges getting access to test kits quantities, that much of this now is being invested in travelers who are leaving the country because travel has opened up. People want to travel and they need this in order to, they need a so-called COVID certificate in order to be allowed to travel. And we are concerned about then how much of the capacity for testing will be invested in controlling and dampening down the potential or the actual upticks and second surges that are happening. I can only repeat, we need good public health interventions. We need it targeted based on data. We need it quick, we need it effective, and we need people to be enabled, informed, understood, so that they play their part in order to contain the second wave or the upticks that we are anticipating are coming because the economies are being opened up in our countries. This is what is needed now.
Thank you very much, Dr. Mweti, and thank you to all the panelists. It has been an informative session. Dr. Matshidiso Mweti, WHO Regional Director for Africa, who's in Brazzaville, the Republic of Congo, and thank you very much, Mr. Prosper Zominto in Dakar, Senegal. He's the Regional Director for Western and Central Africa International Civil Aviation Organization. And thank you very much, Professor Salim Abdul Karim, Director, Center for the AIDS Program of Research in South Africa. He's the co-chair of the Ministerial Advisory Committee on COVID-19 and Professor of Global Health Department of Epidemiology, Mailman School of Public Health at Columbia University. He's in Durban, South Africa. And thank you very much to all of my colleagues who joined us for this briefing. And I hope we did at least try to answer most of your questions. Do enjoy the rest of your day. Goodbye.
Thank you very much.